Okay, good morning, everyone. In continuation with our next lecture series, this is our lecture 2, and this is again a very important lecture where everyone, those who are treating cancer pain patients, they should know how to approach a adult patient who is in intractable pain. If you will not approach properly, if you will not assess properly, you will not be able to relieve pain properly. It is very important. Good assessment will lead to good pain management. And for this team, for this lecture, we have again a very fantastic team which is doing really well in area of palliative medicine, as well as in other areas. Is from Indo-American Cancer Center and Research Institute, Hyderabad. I'll request Dr. Praneeth to introduce the speaker and moderator from this team, and then we will start. Praneeth, please introduce.
Yeah. Good morning, madam. Thank you for the opportunity for giving the opportunity for our institute. Dr. Pulluri Sai Sowmya will be presenting today. She is the first year DNB resident in palliative medicine, and she has a keen interest in management of all symptoms related to palliative care, and especially refractory pain, because that is her thesis topic as well. Dr. Praveen Kumar is the moderator today, and he is my co-consultant, and we both are working together in the Basavatharakkam Cancer Hospital. He is not yet joined. I'll just follow with him. Thank you for the opportunity. We'll start the presentation.
So I request everyone to write your questions as many as possible in chat box, because this topic may prompt you to ask questions, and we will take all the answers at the
end. Good morning to everyone. Today's my topic is approach to an adult patient with intractable cancer pain. The contents which I'm going to discuss today are introduction to the pain, refractory cancer pain, and the management of refractory cancer pain, which includes a pharmacological, interventional, and integrative medicine role. Coming to what is pain. According to the IASP definition of the pain, an unpleasant sensory and emotional experience which is associated with actual or potential tissue damage or described in terms of such damage. According to the revised version, they added the 6 notes, which is pain is always a personal experience and it is influenced by biological, psychological, and social factors. Pain and nociception are 2 different phenomena. And through their life experiences, individuals learn what is the concept of the pain. And a person's report of an experience as pain should be respected. Although pain usually serves as an adaptive role, it may have adverse effects on the function and social and psychological well-being. Verbal description is only one of several behaviors to express pain. If someone which was not able to communicate pain, it doesn't mean that he does not have any pain. Coming to the goals of pain management is to optimize pain treatment outcomes in 5 dimensions. These are usually referred as 5 A's of the pain management outcomes. It will include the first, analgesia. We have to provide proper analgesic effect, proper pain relief. And then coming to the second A is the activities. Optimize activities of daily living, psychosocial functioning, and the adverse effects. We have to minimize the adverse events, and then aberrant drug taking. Make sure that avoiding the aberrant drug taking and preventing the addiction. And then the last A is the affect. It is a relationship between the pain and the mood. Total pain, as everyone is aware of that, pain is considered into the different domains like physical, social, psychological, and spiritual. Before going to the management of the cancer pain, we have to make sure that proper assessment of the pain is very important. Taking into the consideration of the what type of pain it is by taking proper history and assessing the severity of the pain by using different scales like NRS, visual analog scale. And if the patient is unable to communicate, by taking the critical pain observation tool, we have to assess the severity of the pain. And after assessing the proper severity of the pain, the proper type of the pain, according to the WHO ladder, as everyone is aware of it, we have to go from the mild, from step 1 to step 4 gradually, and we can increase our doses. Like in the first step in mild pain, which is from 1 to 3 NRS, we can use the NSAIDs, paracetamol. And then coming to the second step, mild to moderate pain with NRS 4 to 6, weak opioids can be started. And when we gradually increase to the step like moderate to severe pain from the 7 to 10 NRS, and then we can use the strong opioids along with the adjuvants. Before going into the discussion, I just want to discuss some case scenarios. These are the scenarios which are seen in our setup. A 50 years old female, she's known case of carcinoma cervix recurrence. She presented with the chief complaints of lower back ache radiating to the left lower limb with NRS 8 to 10, 8 out of 10, which is dragging, burning, tingling type, and the continuous pain which is aggravating on movement and relieving on the rest. She was admitted in our IP, and we started her on the infusion morphine titration with along with other adjuvant medications were also started. But no improvement was seen in the pain intensity. She was having continuous pain. We then started her on the intravenous lignocaine infusion, but her pain levels improved only to a little extent. She also underwent palliative radiation for the skeletal mets, but after 2 weeks, again she presented with severe pain crisis. She was readmitted again, and we started her on the infusion morphine titration, but no improvement was seen with increasing dose of the morphine. She was crying continuously in the severe pain in the left lower limb, which is of same dragging, pricking, burning, and continuous pain. What could be the inference from the above case? So we can take this case as the refractory cancer pain. Coming to the what is the definition of the refractory cancer pain? Refractory cancer pain is defined as pain which is not responding to the standard opioid therapy with or without co-analgesic therapy. There is no particular standard dose, but in few studies it was shown that oral morphine equivalent which can be taken more than 300 mg daily for more than 24 hours. And in the other study, it was shown that oral morphine equivalent was taken more than 200 mg. Why refractory cancer pain occurs? If there is assessment of pain inadequacy and judgmental error by not using the appropriate opioids, if the patient is not taking the drugs properly, and the disease progression itself, and the opioid-induced tolerance, opioid-induced hyperalgesia, and the development of the central and peripheral sensitization. Coming to the management of the refractory cancer pain. It involves pharmacological management, interventional, and non-pharmacological management. I just want to go into the another case scenario. It was a 48 years old female who was diagnosed with a carcinoma cervix recurrence. She underwent chemotherapy, radiotherapy. Currently, she is on the best supportive care. She presented with the pain in the lower back ache, which is radiating to the bilateral lower limb with NRS almost 9 out of 10, and which is dragging, tingling, continuous pain, which is aggravating on movement. Previously, she was titrated according to the pain intensity, and she was currently on the oral morphine 180 mg per day. She is taking adequate SOS medications also for the pain, but no good relief, and she presented with acute pain crisis. What are the options could be used in her to treat the pain? This is in our case scenario, we tried the opioid rotation in her. So I just want to discuss about the opioid rotation. What is meaning the opioid rotation? Changing or switching from one opioid to the another opioid. What is the mechanism of the action behind it? Incomplete cross tolerance is same, and variation in intrinsic opioid receptor activity, intra-patient variation in the pharmacokinetics and dynamics, and the desensitization of the opioid receptors. When should the opioids be switched? In patients with pain refractory to the dose titration of the given opioid, any poorly managed side effects are present, taking into the consideration of the logistical or the cost concerns, and trouble with the route of opioid administration. like in head and neck cancer, they won't be able to take the oral medications and all. Then we can consider for the opioid switch. Coming to the drugs which are commonly used in the opioid rotation, methadone. It is a synthetic drug. L-isomer is a mu-opioid agonist and D-isomer is a NMDA receptor antagonist. Steady state is usually achieved after 5 to 7 days. The advantages are it provides long-lasting analgesia, high oral bioavailability is seen, good safety in the patients with renal dysfunction, and it is of low cost. Methadone can be available in like either in the syrup form or the tablets form. Coming to the calculation of the dose of the methadone, it depends on the previous opioid dose and the age of the patients. If the previous oral opioid dose is less than 60 mg oral morphine equivalent, then we can take the methadone 2.5 mg thrice daily. If the oral morphine equivalent is 60 to 199 mg and age is less than 65 years, then 10:1 conversion is taken. If it is more than 200 mg and age is more than 65 years, then 20:1 conversion is taken. But make sure that not more than 40 mg per day. Coming to the side effects, methadone most commonly cause QT prolongation. So we have to be very conscious when prescribing the other drugs which also cause QT prolongation like haloperidol, tricyclic antidepressants, ondansetron and olanzapine. It can cause constipation, nausea, vomiting, dizziness. This is an article which shows the use of the methadone switching for the refractory cancer pain. In this, methadone switching was done in the 2 ways like 3 days method and stop, go and stop method. In 3 days method, the dose of the methadone, the dose of the previous opioid is gradually titrated in the 3 days. But in the stop, go, stop method, the previous opioid is stopped aberrantly. So in 3 days method, it showed good benefit when compared to the stop, go, stop method. Coming to the second case scenario. A 50 years old female patient, she was diagnosed with a carcinoma tongue, stage 4. She underwent surgery, chemo, radiation therapy. Currently, she is on the best support treatment. She presented with the pain in the left lower limb with NRS 9 out of 10, dragging type, continuous since 1 week. Sensations are intact. She was previously on the oral morphine 20 mg Q4S, but no good relief. She was again readmitted in our IP and started on the morphine titration, but no pain relief is seen. She was continuously complaining of the severe pain and unable to walk due to the pain. In this case, we considered her for the lignocaine infusion, and we saw a good result. Coming to the lignocaine infusion. Lignocaine, it is a local anesthetic agent, as everyone is aware of it. In low doses, it is also has the analgesic effect. The mechanism of action behind it is it will inhibit the voltage-gated sodium channels on the surface of the nerve fibers and prevent depolarization. It also inhibits the voltage-gated calcium channels, NMDA receptors, and prevent the transmission of the pain. Different studies showed different doses of the administration, doses ranging from 1 mg per kg per hour to the 5 mg per kg per hour infusion. In few studies, bolus dose was given, then followed by the continuous dose, and then in few only continuous infusion was sent. According to the NCCN guidelines, 1 to 3 mg per kg over 20 to 30 minutes bolus was given, then followed by the 0.5 to 2 mg per kg per hour continuous infusion. Good analgesic effect was seen almost for a few days to few weeks after one infusion, and dose reduction of the opioid was also observed. And we have to consider the preservative-free lignocaine in intravenous infusion, as a preservative is a paraben which usually decreases the seizure threshold. The side effects are lightheadedness, dizziness, confusion, lethargy, nausea, and perioral numbness. This is an article which showed the lidocaine infusion. Coming to the next scenario, a 30 years old male patient, he was recently diagnosed with the carcinoma stomach stage 4 with liver node, skeletal, and bone marrow involvement. Thrombocytopenia was seen. He had D11 compression fracture. He presented with pain in abdomen and back with NRS 10 out of 10, continuous, dull, aching, unable to get out of bed due to the severe pain, which is aggravating in movement, and is crying in pain. We started him on fentanyl infusion, titrated according to pain by adding adequate adjuvant medications, and no good relief. He was started on the palliative radiation therapy also for the D11 spine. He developed acute pain crisis after the start of radiation therapy. We started him on the fentanyl boluses, steroids, selective NSAIDs as he had thrombocytopenia, but no good relief. We tried local application Rignofen patch, but no relief. It was really very challenging for us in controlling the pain in this patient. As he is having thrombocytopenia, we cannot give adequate NSAIDs also in the increasing doses. So he was crying in pain and unable to proceed for further radiation therapy also. In this case, we considered ketamine infusion and we saw very good pain relief in him. Coming to the ketamine. The mechanism of action behind it is a primary role as NMDA receptor antagonist. It also has other actions like nicotinic and muscarinic receptors, at voltage-gated calcium channels, GABA receptors, and it will activate the descending inhibitory pathway of the pain. Different protocols are seen for the ketamine infusion. Coming to the burst ketamine protocol. 100 mg of IV ketamine was given over 24 hours and we see its effect after the 24 hours. If it is effective, we will continue it for the 3 days. If it is not effective, then we'll increase the dose to 300 mg over 24 hours and we'll again reassess after the 24 hours. If it is still ineffective, then we'll increase the dose to the 500 mg. But on the 5th day of infusion, whether it is effective or not, we will stop the infusion. And the most common side effect for the ketamine is the psychotropic side effects. So we usually consider benzodiazepines like midazolam prior to the infusion to prevent these side effects. This is an article which shows the burst ketamine for the refractory cancer. And in other studies show the continuous infusion of the ketamine. Doses are ranging from 0.3 mg per kg per hour to 1 mg per kg per hour. And good pain relief was seen post-infusion up to few weeks, and opioid dose reduction was also seen. Coming to the side effects, as I already mentioned, CNS-related effects like hallucination, panic attacks, dizziness, blurred vision, nightmares, vivid dreams, serious related like tachycardia, hypertension, and liver-related like elevated liver enzymes, and GIT and nausea and the vomiting. This is an article showing the use of ketamine in the management of the refractory cancer. Coming to the next cannabinoids, the two compositions like the tetrahydrocannabinol and the cannabidiol helps in providing the pain relief. THC is psychoactive, where the CBD is non-psychoactive. It is administered by the inhalation orally or oral mucosa. The mechanism of action here is it interacts with the endocannabinoid system, which plays a role in pain control signaling. The side effects are drowsiness, slurred speech, dizziness, increased sleep, and confusion. This alone is not taken into consideration in the refractory cancer pain, but as an adjuvant, it provides adequate pain relief. This is an article which showed the use of the medical cannabis in the cancer pain management. Coming to the interventional management, in every cases, first we'll consider for the pharmacological management, even though it is very challenging for us to manage with the pharmacological, then we step into the interventional management. Coming to the different management like injection therapies, which are targeting, and then neural destructive techniques, spinal analgesics, neurosurgical interventions, vertebroplasty, kyphoplasty, and the neurostimulation. Coming to the injection therapies. In this botulinum toxin injection, which is a neuroparalytic agent which is produced by the Clostridium botulinum, the action is irreversibly inhibits acetylcholine release at NMJ and reduces the muscular contractions and the painful muscle spasm. It also blocks the peripheral and central sensitization. It is used in the spasticity, movement disorders, phantom limb pain, complex regional pain syndrome, and chronic myofascial pain. Coming to the next, nerve blocks. This usually implies single shot of delivery of the local anesthetic to the target nerve. Neurolysis can be take place either by using the chemical agents or by applying the thermal energy. Coming to the chemical ablation, in this we use phenol or alcohol. The mechanism is it causes the denaturation of the neural proteins and causing nerve damage. It is usually a painful procedure, so prior to this, we always use local anesthetic. Coming to the thermal ablation, the radiofrequency ablation, it generates area of the coagulate necrosis, and the temperature here is 60 to 90 degrees. The next one is a pulsed radiofrequency ablation. In this, we use burst of the high voltage, which are usually interrupted by the silent phases. In this, low temperature, like below 42 degrees, is maintained. This is an article which is showing the effectiveness of radiofrequency ablation in the management of patients with spinal meds. I just want to describe few blocks which are usually important in our setup. The celiac plexus block, the indications are which are used in the intractable abdomen pain, for the treating pain which is involving the pancreas, biliary tree, retroperitoneal organs, and the other abdominal organs. It is most commonly used in the pancreatic cancer. The contraindications are coagulopathy, infection. The complications are injury to the neurovascular bundles, pneumothorax, paresthesias, and infections. This is an article which shows the celiac plexus block in the management of the chronic upper abdomen pain. Coming to the next block, splanchnic nerve block. The indications are chronic abdomen pain. The celiac plexus block which is failed, we can consider the splanchnic nerve block. Contraindications are as usual mentioned in the previous, like coagulopathy, infection, abdominal aneurysm. As it is a sympathetic block, it can cause complications like hypotension, pneumocylothorax, neurovascular bundles damage, and the organ function. Coming to the next block, brachial plexus block. In this, different approaches of the block will produce different regions of the analgesic effect. In interscalene block, it will cause analgesia to the upper limb from the distal end of the clavicle to the shoulder joint in the proximal humerus. In superior trunk block, same as the previous, but phrenic nerve is paired in this block. In supraclavicular block, analgesia is produced from the mid-humerus to the fingertips. In intraclavicular block, analgesia from the mid-humerus to the fingertip, but intercostal brachial nerve is paired. In axillary brachial plexus block, from the mid-humerus to the fingertips, as in the previous, it spares the intercostal brachial nerve. These are the different nerve blocks in the different regions in the different pains. Coming to the next concept, vertebroplasty and the kyphoplasty. It is used in vertebral compression fractures, which are seen in the metastatic cancer, multiple myeloma, and the bone loss of the radiotherapy or the hormonal treatment or the steroids. It will provide good pain relief in 80 to 90% in osteoporosis-induced fractures and 50 to 60% in neoplastic fractures. Coming to the vertebroplasty, in this bone cement, polymethyl acrylate is injected through needles into the interstitials of the vertebral marrow space. In kyphoplasty, before injecting the cement, we will inflate with a high pressure balloon in the vertebral body to create a cavity. As I already mentioned, first the needle is placed, we will inflate the balloon to create the space, and then cement is injected. In vertebroplasty, no inflation is seen. Directly we will inject the bone cement to the interstitials. The mechanism of action behind this is it will stabilize the fracture size and prevent the painful movement of the bone ends. Contraindications are absolute contraindications are spinal cord compression with myelopathy, spinal instability, osteomyelitis. Coming to the relative contraindications, any posterior vertebral effects, epidural tumor spread, or cervical fractures. The complications are cement extrusion into the spinal cord, and it may cause neural compromise, and it may cause the venous thromboembolism, which can lead to the pulmonary embolism. Coming to the next concept, spinal analgesics. These are usually administered either with the epidural or the intrathecal. The mechanism of action behind this is when we spinally administer the drugs, it goes close to the receptors which are present in the dorsal column of the spinal cord. These receptors may be present on the presynaptic and the postsynaptic neurons. And after blocking this, that nerve signal transmission inhibition takes place between the presynaptic to the postsynaptic. So further transmission of the pain transmission inhibits. This is an image which shows the presynaptic receptors and the postsynaptic receptors and different drugs acting on the receptors and inhibiting the transmission. Coming to this, based on the life expectancy, we can consider either the catheters or the tunneled catheters or the implantable pumps. Different intrathecal drug delivery.
Sowmya, you can explain that previous slide in a bit elaborate manner.
Yes, sir. When the life expectancy is less than 6 months, we can consider either the epidural catheter or the intrathecal catheter. It may be either percutaneous tunnel or the implantable system. If the life expectancy is more than 6 months, first we have to give a single shot trial of intrathecal drug. If the pain intensity is less than 50%, no intrathecal catheter is placed. If the pain intensity decreases by more than 50%, then we can trial with the IT catheter. Again, we have to assess the pain intensity. If it is decreases less than 50%, then we have to reassessment why the pain is caused. But if pain intensity decreases more than 50%, then we can consider for the IT implantable pump. Coming to the intrathecal drug delivery system, as I previously mentioned in the slide, it may be either simple or cutaneous, tunneled, and the implantable drug delivery system. Simple percutaneous intrathecal drug, it is minimally invasive. It can be done by bedside. It is usually done to assess the efficacy of the intrathecal opioids. It is usually done prior to the implantable, prior to placing of the implantable. In tunneled intrathecal catheter, subcutaneous tunnel is made. It exists from the lateral abdominal wall. And in implantable drug delivery system, it uses a small programmable computerized electronic pump which delivers to the IT space and is usually the patient control analgesic pump. Coming to the indications and the contraindications. In indications, spinal opioids work best for the deep, constant somatic pain. Neuropathic pain may require different drug combinations like morphine, like opioids with local anesthetics. Different combinations are used, and it is also used in the opioid tolerance, refractory cancer pain. Coming to the contraindications, any coagulopathies, septicemias, immunosuppression. Spinal meds is not a contraindication. Coming to the side effects, like systemic opioid side effects, it also causes side effects like constipation, nausea, vomiting, itching, sweating. Coming to the next, neurodestructive interventions. When it is a unilateral pain, we can consider percutaneous cordotomy. In visceral pain, punctate middle line mylectomy. In diffuse pain syndrome, stereotactic cingulotomy. Coming to the next concept, neuromodulation. The neuromodulation means it involves the chemical or electrical modulation of the central and peripheral nervous system to modify symptoms of the diseases, like including the pain. Types of neuromodulation. It may be either invasive or non-invasive. In invasive, peripheral nerve stimulation, spinal cord stimulation, motor cortex stimulation, and the deep brain stimulation. In non-invasive neuromodulation, transcutaneous electric nerve stimulation, transcutaneous vagus nerve stimulation, transcranial magnetic stimulation, cranial electrotherapy stimulation, and transcranial direct current stimulation. Coming to the spinal cord stimulation, it delivers electrical stimulation to the dorsal column of the spinal cord using the electrodes implanted in the epidural space. It's most commonly used. What is the mechanism of action behind this? It is usually based on the gate control theory of the pain. Gate control theory of the pain is nothing but I just want to give a small example. Whenever we get a hurt in any place, we usually immediately rub that area and we feel little relief from that. What does it mean? Usually pain is transmitted to the A delta and the C fibers, which are usually the small fibers, and the touch vibration, these are usually transmitted by the large fibers. So whenever in the same mechanism is seen here, so whenever we rub, the transmissions are usually taken into the large fibers and small fibers are spared. The same thing is seen here. The large fibers are activated and the small fibers, which are usually the pain fibers, are not activated. The other mechanisms of the pain relief, like activation of the descending inhibitory pathway and down regulation of the neurotransmitters. It is used in the refractory neuropathic pain, complex regional pain syndrome, and the phantom limb pain. The gate control theory, which I described just now. And coming to the individuals like occipital nerve stimulation, when do we consider? We consider in the greater occipital neuralgia, which is the most common cause for the headaches, tension type headaches, whiplash injuries, and the migraine headaches. Coming to the thoracolumbar spinal cord stimulation, indications are failed back syndrome, uh, failed back surgery syndrome, sympathetically independent pain of complex regional pain, chronic intractable anginal pain. Coming to the sacral nerve stimulation, the indications are any voiding disorders, chronic pelvic pain. Coming to the motor cortex stimulation, indications are trigeminal neuralgia, complex regional pain syndrome, and phantom limb pain. Deep brain stimulation indications, intractable headache, peripheral and central neuropathic pain, cancer-related pain. It is also used in the Parkinson's. Coming to the transcutaneous electric nerve stimulation, which are used in the phantom limb pain, central pain due to the spinal cord injury. Coming to the next, integrative interventions. So the patients with the cancer experiencing pain, the different symptom settings by different integrative therapies like acupuncture, yoga, massage, and hypnosis. These are also had the role in providing the pain relief. For the pain management, it not only included the pharmacological, complete holistic approach is required to decrease the pain. Coming to the next concept, end of life pain. The patients nearing the death, pain is always perceived to be refractory because these are usually accompanied by other symptoms like dyspnea, agitation, delirium, anxiety. This usually exacerbate the underlying central pain mechanisms. All possible causes of suffering must be carefully assessed and evaluated by means of the multidisciplinary team approach by taking into the consideration of the psychiatric and the psychological approaches also. And in this setting, sedation is the only therapeutic option. And the drugs which are commonly used for the sedation are the opioid, neuroleptics, benzodiazepines. And the selected and administration initially requires first we have to dose titration to achieve the adequate relief. Then we have to maintain the dose to produce a maintenance effect. And the take-home message for today's class is refractory cancer pain treatment is quite challenging. So before pain going into the refractory, we have to do proper assessment and the proper treatment in the early stages may prevent the development of the refractory cancer pain. And total pain is always considered and different domains of the pain should be treated. And interventional pain procedures can provide appropriate analgesia where opioids are ineffective, as now better imaging techniques are available. So interventions are safe and more effective. And as already told earlier, holistic management, which include not only on the intervention, but also the integrative management will help in the adequate pain relief. These are my references. Thank you.
Yeah. Good morning, everyone. Firstly, sorry I was joined very late due to some personal and technical issues. Yeah, thank you, Soumya.
Thank you.
Yeah, for your comprehensive presentation. Yeah, as we discussed, this refractory pain is very quite challenging because these causes of the refractory pain is quite multifactorial. And in the literature, till now, there is no standard definition for the refractory pain. So now it is very essential to establish a standard definition for the future modalities. And we know till now, in spite of that, there is number of advanced technologies and modalities to treat the refractory pain, like intrathecal drug delivery systems, deep brain stimulation, spinal cord stimulations. And there is a lot of research and studies are going on with the newer pharmacological substances like ketamine, xalacad, ziconotide. So much of development occurs in non-pharmacological. Also, there is integration of the integrated medicine for the non-pharmacological treatment along with the standard opioid therapy. But along with that, in spite of that, when you are dealing with the refractory pain, one shouldn't remember that we need to take the proper history and clinical examination and good pain assessment and involvement of the multidisciplinary teams like primary consultants and other specialties like psychiatrists, psychologists when they require. And most important thing is use of multiple drugs, so that these drugs are act differently on the different receptors and different types of mechanisms, so that we can come down the adverse effects of the individual drugs. And most importantly, holistic approach is most important to achieve the case of goals in these refractory patients to relieve the pain. Thank you. Now I open for this topic for discussion. So any inputs and any questions we'll discuss. Thank you. Thank you, ma'am.
So there are a few questions. Can you take up the questions first, please?
Yes, ma'am.
Praneeth is 130.
For single shot of ma'am, for single shot of intrathecal epidural injections or refractory neuropathic pain, what is the dose of type of medicine used? Also, it is used mainly for the lower limb pain. So, ma'am, it's all depends upon the what type of injections you are giving for the single shot. So generally for the neuraxial opiates, we are using local anesthetics along with the adjuvants combination therapy, like we'll add some clonidine. So if you use single local anesthetic, there is a duration of action for the 3 to 4 hours. And if you add something like clonidine, morphine, fentanyl, the duration of action of the combination drugs will be increased. So it's all based on the what type of medicines you are using and what type of adjuvants you add into that local anesthetic.
So basically, single shot epidural we have tried for refractory pelvic pain in a particular patient. Yeah, but there are other challenges also in giving epidural in this patient, because the positioning will not be very comfortable. And coming to the dose of the local anesthetic, that it depends on the body weight and whether you want to give a single shot or want to put a catheter and then give a continuous infusion. So the multiple factors. Usually we can try the dose approximately 7 to 8 ml of 0.25% or 0.125% of bupivacaine plain, and see the response. If the response is good, we can consider for a catheter insertion as well.
And we can there is a calculation like morphine equivalent doses. If with the 24 hours of oral dose for the epidural, it's 1/10, 10% of the total 24 hours oral morphine dose. And for the intrathecal, it is 1% of the total 24 hours oral dose. This is a morphine equivalent dose for the epidural and intrathecal.
So I think for epidural, it will be, for intrathecal, it will be oral versus 300 times less. 300 times less. So
Yes,
whatever.
yes, ma'am.
Yeah.
Intrathecal is 300 times more potent compared to what oral morphine can be. So the dose which we have to give in intrathecal will be 300 times lesser compared to the oral morphine equivalent.
So I want to add something in this class, Praneeth. Actually, whenever patient with intractable pain means a patient is coming who is not getting relieved with any medication, or he is having severe pain, howling, crying, there are only two reasons. One is very uh, atypical pain, like pain is coming only from nerve complex. Now is compressing. Now is damaged. Patient, the tumor is encroaching nerves, or there can be another reason that is purely that whatever medication you have written, which is not which is a poor compliance, whatever medication you have taken because of many reasons, because of fear, because of myths, he has not taken medication properly. This can be the one reason. Another reason which I have felt, and I think this we should document always, that many a times patient is intractable pain, and when you start talking to the patient, start listening to the patient, and you will feel that the same patient who was howling and crying is now talking to you very nicely. So now the 50% of your component has gone when you have listened to the patient properly. There are so many other concerns. And though so many, we will not discuss all the concerns in detail, but we know that nobody is listening to her. Nobody, she is not understanding what is happening to her. What will be the realistic treatment for the disease? What will be the, how much pain will get relieved? How will she will take care of this? She wants to ask you everything, which you have to just listen. And I have seen the patient which they have come with intractable pain, and only by listening, not listening does not require half an hour or 15 minutes, just listening 2 or 3 minutes properly what she wants to say, patient will get relief. So there always, whenever patient intractable pain patients comes, please rule out first that whether there are so many unanswered questions which she wants to say, so many unanswered statements which she wants to ask you. Please do that. Second thing, whatever medication you have prescribed, whether she's taking regularly, whether there is compliance is good or not, this you should definitely rule out. And then only we should jump on the atypical pain, that is intractable pain, which everything which we have discussed about nerve blocks and all these things. And this will come only at the last. So definitely there is a strong role of intervention in cancer pain management. Everybody should now there are all institution based practices going on, so everybody should integrate pain team in your pain management, in palliative care team. You should learn that what are the various intervention which can help patient in giving pain medication. Even if intervention, by giving intervention, you will relieve pain, you will improve quality of life by decreasing opioids and other medication which causes excessive side effects and unnecessary side effects. So early intervention to intractable pain medication intervention is a role, but please don't forget about unanswered question, listening to the patient, because other aspects are very, very important. And you will realize it when you will start doing like this, that why she is crying so much, why she is having so much of pain, when I have started medication properly. Then just when you will check, she will say that, yes, I'm not taking, I'm afraid of taking medication. This will cause me sedation. I will not be able to do my daily activities. And this is the way you can approach your patient when patient has come to intractable pain. And there is a definite role of intervention. There is no doubt about it. And it is not only at the time when patient is howling and crying, it is right from the beginning, there is a role of intervention. Any senior person wants to add something, please? Or anyone wants to add something? So Nandini has written something. Nandini, can you open your mic, and then maybe if Dr. Jennifer, Dr. Shobha, or anyone, Dr. Jennifer is there, she can add.
Hi, Sushma, thanks. We are really truly appreciative of the comprehensive presentations. What happens is, again, it's just a kind of a flyer that this can be done, that can be done. Now that we are at a stage of, advancing this into another level, I feel we should have a little more detailed presentation on selected interventions and talk in detail about how to select those patients, because that is the most important step in an intervention, right? So selecting the right patients who have a specific nerve to be intervened with, or, specific system to be, utilized for. So selection of patients would be a very useful right from there. And then the communication that precede the interventions. How do we come down to a particular specific diagnosis and the choice of modality? And then the preparation of the patient. Then we can have in that same presentation a detailed video of how this technique was done. And then how do we follow up that patient? And then what are the complications? And, how do we manage that? So, that will really empower the audience a little
So,
more.
Nandini, this was not not the class they could have done this. There is a
Yeah,
lot
yeah,
of
yeah.
topics on this.
Fully,
Topics are
fully
coming
understand.
on. Subsequently, there will be topics which will be covering specific blocks, and maybe one overall presentation we will take, and then each block we will give you in details in subsequent topics. Definitely.
Yeah, yeah, thank you. And even in that block, it should be right from the, conversations as to how do we understand that this block is the right one. Then the preparation, and the, telling the patient the consent format, in the sense, what all do we talk to them about? So it can be a total learning experience. Yeah, this is excellent that we have started off. But I was just suggesting that, for those who don't have an active intervention team in their hospital, it will really help. And also some resources where they can go and learn, they can go and practice. So all of that can be brought in. Thanks a lot, Sushma.
Dr. Jennifer.
Meenakshi madam had raised her
Dr.
hand.
Meenakshi, go ahead, please.
Yes, good morning, ma'am. Thank you. That was a very comprehensive and precise presentation, Dr. Sowmya. Thank you for that. I just wanted to add in a few points in the in this topic. So one is you talked about ketamine. So if the intravenous route is not available, maybe the patient is living far away, cannot come on subsequent days, because we can give it up to 5 to 7 days according to some of the studies. The oral ketamine route can be used, and up to 4 doses per day have been described in various studies. So that is one thing which one can do. And ketamine is very valuable in refractory, especially if there's a neuropathic component or a bony pain. Bony pains are one of the most difficult to manage. People who develop bony metastasis in various places, you start radiation here, radiation there. I mean, at one point you'll reach where you need to go for other agents. And the second point I wanted to make was with reference to methadone. So I saw the conversion table that you had provided. So a valuable resource which I can direct you to read is Maryland McPherson, University of Maryland at Baltimore. Their paper on the usage of methadone using the white paper consensus is a very simple to use for people who are not familiar with the drug. It's a very simple to use document, and I would urge you to urge other participants who are not used to methadone to definitely read up that paper, because it makes the dosing very simple, very, very simple. Yeah, those are the 2 points that I wanted to make. Thank you.
Yes,
Madam, can you prescribe ketamine to home, madam?
Yes, we do that very regularly in our center, because many patients are not, they are from rural Tamil Nadu, so they just come in for their cancer appointment, and then they need to leave the same day. So we give the first dose in the OPD under monitoring, see the response. If we find that the pain score is reducing, then we load up the drug in the syringe and give them a week's supply. Actually, I think they can keep it up to a week to 14 days is what I have read up from various things. So at least 7 days 7 to 10 days, we have sent them with oral ketamine and found very good results. Just to continue that 5 days, instead of the continuous infusion, and they'll have to stay in the local place. Instead, as a replacement for that, the first day is IV, the rest of the days is we manage with the oral formulation. 0.25 milligram per kilogram body weight itself suffices, never gone up beyond 0.25 actually. So there are no side effects. It's a bit bitter. So what we can tell them is to mix it with some strong citric kind of juice like orange or something, and ask them to take it. Works very well. Thank you.
Thank you.
Anyone else wants to add something?
We too, and Dr. Nandini here, follow up with Meenakshi. Often we maintain the pain relief which has been achieved with parenteral ketamine infusion. We also use subcute, and if pain is there, we'll use IV. After that, during discharge, we follow up with sublingual ketamine. So we have a kind of format through which we can dispense loaded syringes for them to use sublingually. And the dose can vary anywhere between 15 milligrams to 25 milligrams under the tongue. Then slowly we wean it off. And this has really helped, especially patients with the chronic regional pain syndrome or, very complicated pains and refractory pains. Thanks.
There is one question by Dr. Preeti about the use of preservative-free Xylocard. Definitely in the IV infusions that we use only Xylocard, which has a preservative treatment. That is the only, and we do not use lignocaine, which is given for blocks or in local anesthesia for IV purpose. And there is another question by Dr. Manish about whether there is a separate preparation available for oral ketamine other than the IV preparation. I don't think so. Maybe Meenakshi Madam or Nandini Madam can comment on.
No, actually, the ketamine preparation is the intravenous preparation, which we dilute in the syringe and give it and use it orally. I am not aware of a selective oral preparation.
Yeah, same here. We use the injectable preparation. Only thing we don't dilute, because the lesser the amount dropped into the sublingual space, higher chance it will stay there. The more volume, they will just drink it, and bioavailability is low. And so we can afford to use a smaller dose if it's given sublingually. Here we are relying more on transmucosal spread. And so we use the same injectable. Only thing, there is a limit to how many syringes you can load and give. So we generally give them 3 syringes, which is usually sufficing for a week or so. Thanks.
So for oral ketamine, I have one thing to add, that oral ketamine is very, very bitter. So if at all we want to give liquid oral ketamine, we have to give it some kind of a honey. This is I'm telling because in 1999, we did one randomized control trial, I think, which is the maximum cited paper till now in Journal of Pain and Symptom Management. If you can go and read this paper, oral ketamine for neuropathic pain, pain management. And what we have observed, that we used to give oral ketamine. It's like it was very difficult to get oral ketamine. It is still not available. So whatever medication we have given, patient used to get relief, but there were a lot of side effects as well. So ketamine has got side effect, but definitely ketamine has got a good analgesic property also. So whether you are giving subcutaneous, IV or oral, I think we should know how to give it. And I think this can also be one of the topics to discussion. There are so many topics to discuss, and only one day is available in the week. We'll see. So we have 4 more minutes. If there are any questions, Praneeth, otherwise we can stop here.
Can I just say a word?
Yeah.
Yes, please go ahead.
Dr. Stanley here. Sorry, I just joined a few minutes ago, so forgive me for that. The only thing that I want to stress is when we send patients home, and it is not supported by good palliative home care, then when they are not able to take their oral medication, they can have intractable pain. Severe pain can surface again. And so it is very, very important. What I want to stress is that every palliative care setup in our country should have its home care situation, or have a good networking where a good home care support is provided, so that we can empower the family and they can use the subcutaneous route and the family driver that we have been talking about, and use the intermittent method, because continuous method may not be practical in our country. So I just want to stress that. Thank you.
It's a wonderful dream situation, Dr. Stanley, that every palliative care team should have a home care team. And people are trying their reason individually. And hopefully there will be a day when every palliative care team will have a home care team.
Thank
So,
you.
Praneeth, or any other question?
Nothing,
Yes,
madam.
please.
Actually, yeah,
No.
thank
Okay.
you. Okay. One thing which, like rightly pointed by madam, like when we listen to the patient, most of the worries are gone. And this I've seen very practically. That many patients are referred to us from outside centers after a failed intervention or after improper management. Mostly they are uncertain about their cancer prognosis. They are referred to the pain management, telling that if the pain is controlled, we'll look after the further treatment options. But in reality, they just want to pass the situation. So honest and open communication is the first step in management of refractory pain, as rightly pointed out by madam. And
This
yeah,
is
Dr.
a very
Praveen.
important point, Praneeth. I will definitely share this. That the statement by an oncologist that when pain will be relieved, I will treat you. When they know that they cannot treat the patient because it is uncurable,
Definitely.
I
Very
think this
practical.
is such a devastating statement, because patients start thinking because of pain, I'm not getting treatment. So this is again very, very important and devastating situation where patient is not knowing anything, but just thinking that because of pain, he is not ready to treat me. So this is, listening is very important. I consider intractable pain. I think just listen to your patient. What are their concerns? And 50% of pain, definitely, whatever it is, even if it is coming from your nerves, it will get relieved. But definitely there is a strong role, and there is a strong role of intrathecal neurolysis as well. I think Dr. Seema Mishra, our team, she has given one to one patient, a teenager patient, and she wanted to go home, and just there was no way to send her home, and just doing intrathecal neurolysis, she was completely pain relieved, and we were so satisfied that we could send her home. So there is a role of all the medications, and as Nandini said, that we should have a clear-cut idea that which intervention, when to use, and how to communicate. We'll try to take up it one by one. Thank you very much. Thank you, Praveen, Soumya, Praneeth.
Thank you, ma'am.
Thank you, Nandini and Dr.
Thank
Meenakshi,
you.
for sharing your experience, and Dr. Stanley. And thank you everyone for listening carefully, patiently. We will see you again next Monday before 6:30. Thank you, Archana and Nisha and Asha. Thank you very much for organizing and coordinating so well. Thanks a lot.